You mentioned statins. Let's bring that in.
Okay, they're very effective at lowering cholesterol. They're very effective at lowering cholesterol. Of that, there is absolutely no doubt. And if you go on and put in they're basically HMG reductase inhibitors. So if you put in on a search engine the pathway by which cholesterol is made and the pathway by which statins block cholesterol, you come up with pretty much the same diagram. So at the bit where you've got the sort of HMA reductase, that's where statins operate. And they basically impair that function in a pathway of the body. So immediately I'm thinking, I think my body's pretty well designed. I trust my body more than I trust the pharmaceutical industry. Immediately I'm thinking, I don't want to be blocking any pathway that my body has it. I kind of assume it's got it for good reason. And actually it does have it for good reason, because cholesterol is the absolute foundation of every single cell in our body. It is impossible to explain how important cholesterol is to the human body. If we didn't have cholesterol in our body, we would be a puddle on the floor. We'd be dead. We'd be no human. We'd be nothing. Statins then operate at that part of the pathway. Now, one of the things in that pathway, at the bottom of that pathway, is something called CoQ10, which is also called the body's energy spark plug. So sometimes if people say to me, oh, I'm just feeling really white, really tired all the time, I might suggest to them, hey, why don't you just go and get a supplement, quality supplement, maybe try a bit of CoQ10 and just see if you can get that sort of spark plug going again. When they first developed statins, they put CoQ10 into the statin formula because they knew that they were blocking that pathway and they knew that they were going to affect your energy spark plug. But then for whatever reason, my guess would be cost, they just dropped it. So they block that pathway. They don't block it entirely, because if they did, the very first person who took the very first statin would have dropped dead. If you manage to stop the body instantly making cholesterol everywhere and every cell, you become that puddle on the floor. You're instantly dead. And there's actually part of me that wishes that had happened, because then we wouldn't have this whole statin industry. But we do have the statin industry, and we have redefined what normal cholesterol is along the way. So when I try to research to see the normal distribution of cholesterol, and I try to go back about 30, 40 years before we started statinating as many people as we could, your normal cholesterol level, do you deal in MMOL or do you deal in the MG DLs? I don't know. Which one are you?
I'm in Canada. I'm the same
Okay.
as you.
MMOL, brilliant. So normal distribution, I mean, the cholesterol, total cholesterol would go anywhere from 2 to 3 to 9 to 10. And in certain exceptional circumstances, you would have people over 10. But your main part of your normal distribution was anywhere between 2 to 3 to 9 to 10. So the actual norm was around 7 to 8. And that was the norm. But of course, they redefined the norm. And if you look at the history of people who were involved in redefining the norm, it was very heavily influenced by the pharmaceutical industry. So imagine you've got the norm at about 7 to 8, and then you just say 5 is now high. Well, you've just made 75% of people who were on the normal distribution, who still are on the normal distribution, you've now just made them in the high cholesterol category. It's just a stroke of a pen. In a stroke of a pen, you make 75% of the population eligible for statins. And when you add in sort of things like risk assessments, Malcolm and I have played with this. So everybody has what we call a statin by age. So if I play with the risk calculator in the UK and I put in my blood pressure is really low, my cholesterol is actually really low, it's a shame, I'd like it to be higher, my BMI is really low, I'm female, I've got everything on my side, I'm not diabetic, put in all of that, and then I just change the age. And when I get to 67, they want me on statins. Doesn't matter that I'll still be in perfect health. None of those parameters will have changed. I should be on statins. And it can't be right that every one of us should be on a drug at a particular age, particularly because our cholesterol actually should go up as we get older, because we need more repair in all of our cells and everything else going on in the body. So it's a massive industry, massive number of people are on statins. Yes, they will lower your cholesterol. Do they actually have any impact on things that matter? I'll take a breath in a minute, see if you want to go there. And then we might want to get into side effects as well, because they are often also not talked about.
No, this is great. Take a drink of water and we'll continue.
Brilliant. Right, I've actually just done a deep dive into statins. I've just published 3 notes. And what I really wanted to look at, because it's so seminal in the prescribing of statins, is there's a group in Oxford in England, and they're called the CTSU. I can't even remember what that sounds. It's something like Cholesterol Treatment Service Unit or something. And then you've got the CTT group, which is the Cholesterol Treatment Trialists group. So it's a sort of, it's a unit. It's an actual physical unit that employs hundreds of people based at Oxford University. And then it's a research team based at Oxford, but they will also collaborate with people further afield. So sometimes you look at some of their papers and there are hundreds of names of collaborators on the papers. So they have done the seminal work. So they've basically done 6 systematic reviews and meta-analyses. And as I said earlier, that's the highest level of evidence. That's what I did with my PhD. So what they've done is they've pulled together all the statin trials. So in my first note, I looked at, right, what are all the statin trials? How many do we have? Which ones we're looking at statin versus a placebo? Which ones we're looking at higher dose statin versus lower dose statin? And there are 28 of them. Now in there, and they were all but one had the manufacturer of the statin, what Michel de Lorgrill, Dr. Michel de Lorgrill, who've written a lot about, he did the Leon Heart study, written lots about the Mediterranean diet. He looked at all of these and he said, there's only one where I wouldn't actually describe it as the pharmaceutical company is omnipresent. They're doing the stats, they're funding the trial, they're running the trial, their staff are involved in the trial. They are omnipresent, as he described it. And of course, the one that wasn't, that was actually independent, it didn't find anything. And actually, most of the ones even funded by the cholesterol statin manufacturers didn't actually find anything. So you've got these core 14 trials. And they did a paper in 2005. And the first paper was, is there benefit prescribing statins? So to basically show that there's benefit, you've got to be getting into all-cause mortality. Because if you're into, oh, well, you had fewer heart attacks, but we gave them more cancer, or there was more suicide because cholesterol was so low and there is an association there, you've just got to look at all-cause mortality, because somebody's either dead or they aren't. Did they have a angina attack or did they have indigestion? That's a whole different ballgame. Did they die or did they not die? Now, the actual relative risk was very, very small, and they'd done a sort of modelling technique even to get that relative risk. So they didn't just look at how many deaths were there in the statin arm, how many deaths were there in the placebo arm when we pulled all of these together. They did it with a sort of modelling technique of per 1.0 mmol per litre reduction in LDL cholesterol, which is quite high. That's really quite big as a intervention reduction in cholesterol. The placebo arm would not have achieved that at all. So kind of all your deaths are going into one sort of measure on the placebo side, and then maybe not all of your deaths are going in on the other side. Anyway, so they managed to get it off the line of no effect, despite only 3 of those trials individually made any claims for all-cause mortality. They were so compromised. I could go into some of those. Anyway, they start off with this baseline in 2005, and I said, with all the caveats, if they won't allow any other research to access the data, they don't necessarily look at side effects and balance those out. With this modelling technique, with the fact that pretty much all of the people they were looking at, or 80% of them were male, 60% of them were not well, so we're not looking at healthy people, we're not looking at women, all of those caveats, they managed to nudge it off the line of no effect. When you look at the absolute risk, it's really like, do I care? It's like 1 in 100 or something. It's just not impressive. So I then followed this through and I said, right, they used those core 14 again in 2008, and their research question was, okay, does it make a difference to people with diabetes? And I had not spotted this until I went into the deep dive. In the abstract of that paper, 2008, and I've just put this on OpenView, so go on my site, put in CTT statin papers, you can see the whole thing. In the abstract, they say, so the relative risk reduction was 0.91 brackets, and the confidence interval includes 1.01. So you've included the line of no effect. That is a non-significant finding. and it is not reported as a non-significant finding. So you didn't find anything for diabetes, so we can dismiss that one. So that's 2008. 2010, they say, right, let's look at more statin or less statin. Now, the bit in this note is just hilarious because I was trying to separate out more versus less statin in all of those. They're now up to 26 trials. They've pulled more trials, but only 5 of them look at more versus less statin. So I go to Grok and I say, right, does it split it out anywhere? And Grok comes back and said, yeah, it does. And here's the result. And it's like 9% again, and it includes the number 1. So it's a non-significant finding. And I'm like, where have you got that? And Grok says, oh, it's on this page. And I'm like, I'm looking at that page. I can't see it. And Grok is like, yeah, it's there. And then there's a table. And I'm like, I'm not seeing this. And then Grok says, right, show me your page 1676. So I do. Grok comes back, oh my goodness, I'm so sorry. You're right. I'm looking at something that I've got in my data bank, which was an earlier version of the manuscript. So an earlier version of the published manuscript said, when you just look at those 5 trials, it doesn't count. I'm like, Grok, don't apologise. I am so happy. This is amazing find. Thank you. Then I move on to 2012. 2012, they're trying to say, can we show that statins work in people at low risk of heart disease? And they muddy it with people who haven't had previous vascular disease. They're different things. Having had previous vascular disease is different to low risk of vascular disease, which they define as a risk below 10% over the next 10 years, 5 years, whatever. They didn't put that data in the main paper. I found it in the supplemental. When you look at the data for low risk, it again does not achieve statistical significance. You can dismiss that one. 2015, they move on to women. Go to the supplemental again. There's no difference in deaths from vascular disease, no difference in deaths from not vascular disease, no difference in any other deaths that they can't even define. And yet they claim there's a difference in all deaths overall for women. It's like, I'm not buying it. And then the last one was one that I reported on at the time. That was 2019. They said in elderly people, there were big headlines across the UK. They did a big press conference, this Oxford group. They said if all the over 75s were on statins, 8,000 lives could be saved. So I looked at, this is the main paper now. I looked at the over 75s. There's no statistical significance for deaths. Over 70s, the same. So 70 to 75, the same. I looked at in primary prevention, which is what they were claiming. So in people who haven't had a heart attack yet, whether they're in the over 75s or whatever, no statistically significant difference. I mean, I don't know what to call this other than scientific fraud. I just don't know. I mean, I can call it naughty. I can call it disingenuous. You know, there are hundreds of people working on this. This is not incompetence. And this unit, there was a big hoo-ha that involved Dr. Asim Malhotra and Dr. John Abramson and the BMJ and the editor of the BMJ, Dr. Fiona Godley at the time. And the Oxford group had basically taken issue with a couple of papers that the BMJ had published by Asim and John Abramson, and Rory Collins, who's the head of the whole sort of Oxford unit, had said to the BMJ, you've got to retract those papers, you know, it could cause untold harm. And Fiona held firm and said, you know, I'm going to set up an independent panel and we're going to look into this. And as part of that independent panel, they requested the pharmaceutical funding to the CTSU and the CTT paper group. And at that time, this was back in 2014, I added it all up. They sort of like, oh, you know, we got this from Roche and we got this from Pfizer and we got this from Bristol Myers Squibb. And they were all millions and millions. And it added up to 268 million. I mean, that will be 400 to 500 million now. And those guys don't think that they have any conflicts in doing this work, and they won't allow people like me, Dr. Malcolm Kendrick, Dr. Marianne Damasse, they won't allow us access to the raw data to actually look at the numbers for ourselves. So that was my recent deep dive, which was, as you can probably tell, a lot of fun.
Given all that detail, it sounds like the answer is no. But can you think of a specific population, again, looking at the end result, deaths, that can benefit from a statin?
Yeah, and I asked that question. I can't remember which note it's in. I think it might be in note 2. And there is some evidence that in particularly males who have had a heart attack, there might be a benefit of a statin, but it then immediately comes with caveats. So what Malcolm does, which I think is brilliant, is said, we've got to stop talking about lives saved, because we're not God. We can't save lives. All we can do is delay death. And that's what you're kind of looking for, aren't you? You're looking for, cancer looks at it in terms of medium likelihood of years of survival, and that's what you're interested in. I've just been diagnosed, how long have I got left, doc, kind of thing. So this idea that statins are going to save lives, or this intervention is going to save lives, it's a misnomer, because we can't save lives. So by how long might we able to extend a life? And Malcolm does the research on a particular study that claimed a difference for all-cause mortality, which was the HPS, and I'm trying to remember what that stands for. It's a very famous study, which the CTSU were involved in, by the way. So Malcolm did some research on that, and it's like, basically, you're going to extend it by days. And then there's another very famous study that was done by, I think it was Dutch lead researcher. And again, they said, okay, so if you take statins for 5 years, we're not saving lives, but what's the kind of life extension that we're looking at? And it was something like 3 to 4.4 days or something like that. So take them for 5 years, you're going to buy yourself a few more days. Nobody knows that. If a doctor, I know Dr. Asim Malhotra will present that kind of position to his patients and say, okay, yeah, you've had a heart attack. I'm now in the position where I'm saying to you, do you want to take a statin? Because there is some evidence that it's going to benefit you, but it's probably on other evidence, not influenced by the pharmaceutical industry. It's probably going to buy you a few days. And then we need to factor in what else is going to happen within that 5 years. So if you go to this fabulous website called the nnt.com, that will work out for you what we call the number needed to treat and also the number needed to harm. So the number needed to treat will be, let's take the flu jab, because that's very topical at the moment. So we've got a Cochrane study, high gold standard study before Cochrane went off the rails. And they said, what's the number needed to treat with the flu vaccine to avoid one case of flu in adults? And it's 71. So 71 people need to get vaccinated for one person to not get the flu. That's not great odds in my book. And when they look at statins, so in secondary prevention, you've had an incident, it's going to be under 1 in 100. So I think from memory, it's something like 1 in 80 something. So you've got a 1 in 80 something chance of avoiding an incident, which might be angina. It might be having a stent fitted, which is a procedure rather than an event, and it's a subjective procedure at that. But then go and have a look at your numbers needed to harm. So the same group of people taking the statin for 5 years have got a 1 in 50 number needed to harm for type 2 diabetes, which is pretty serious, and a number needed to harm of 1 in 10 for muscle damage. And a lot of people stop taking statins because the side effects are so noticeable and so debilitating that they just say, do you know what, I don't even care if this is going to save my life. They don't know about the days saved. I don't even care. I can't even remember where I've left my keys. My brain has gone to mush. My sex drive is on the floor. My get up and go has got up and gone. My muscles ache, my joints ache. Life is just miserable. I'm just coming off them. And most people who come off them, everything then will go back to normal within a couple of weeks. Mostly they don't leave lasting damage. So if you're feeling bad, then you could always come off them. That's not advice, obviously. That's a suggestion.
If you enjoyed that clip, you're going to want to head over here and catch the full episode. I'll see you over there.
The demonization of fat, the demonization of saturated fat, the demonization of cholesterol, all these things that we got wrong have just then been the bedrock of everything else that's gone wrong since. Fibre is literally many sugars of the indigestible kind.